Right. So the endometriosis can cause adhesion, but adhesion will not cause the ovarian function reduction. Okay. So endometriosis falls. Endometriosis will not affect the ovulation. Will not. It's so can endometrioma affect the ovarian function? Still, again, the endometrioma might affect the ovarian function. It will not affect much about the ovulation, much in the ovulation, because endometrioma can affect the ovum quality, right, Nuandi? So I don't think so. So the answers are true, false, false. So if you see the students who came to the theory part, so when you compare the session 1, session 2 was bit interactive. Then session 3, most of the students were interactive and answering, and it was very, 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 very interactive classes. So more than that, the emergency was fantastic, right? So if I get 450, 430 students, so from the beginning until the end, 430 was there. There were no fight with my coordinator. So the coordinator, no need to ask them to switch off the camera, switch on the camera. So everybody switch on the camera. Even sometimes they might leave the meeting due to some internet issues. Then they are sending the SMS to coordinator, please quickly let in into the class, because they don't want to miss the class even a minute. So it was fantastic. So hopefully I'm expecting you to interactively participate in the paper class as well. Then only it will be a useful event. You people might have a lot of questions, so the answers might be wrong, doesn't matter, right? So if you do, I'm always telling to my students, if you do mistakes now, right? So now Lakshi answered wrongly now, right? Will you lose something? No, nothing you will lose. You will gain something, because I will teach you, no, this is wrong, we have to think in this way. But if you are keeping your mouth quiet, and if you do mistakes in the exam, will you lose something? Yes, you are going to lose your internship, you are going to lose your period, you are going to lose your salary. So you have to think that. So don't think about the others. So don't think about Kitumini, don't think about Takshila, don't think about these boys who are in the class. Right now they might laugh at you, but then once they might get through the exam, they might earn 2 lakhs per month. That time again you will pay 1,400 per class, and you will be in front of computer, or you might be in the tuition centers, right, for the ERPM class again and again. So it's nothing. So don't think about the others, think about yourself. Okay. So the good thing is, during the emergency session, I got a few SMS from the students saying, sir, you always asking question from the front page students, why can't you come to back page and ask question from us as well? Because if you ask question only, we can think and study, it's stimulating us. So then actually I was very shocked, and I almost going to collapse because of the adrenal surge. So am I in this Sri Lanka? Am I teaching to the ERPM students? I was thinking whether it's stream or not, because it's really good. Students wanted to ask some question and wanted to answer the question. It's fantastic. So please study like this. Not only obs and gynae, also other subject. Ask a lot of questions from your teacher. Then only you can study. You have to clear all your doubt. Right? Okay, Janet. Thank you. So question number 2, shoulder dystocia management. Commencement of oxytocin will aid the delivery. What do you think? Commencement of this one. Shamira, what do you think? Commencement of syntesinone will aid the delivery. True or false, Shamira? Only answer just true or false. Yes, Shavin. True or false?
False.
Okay, so it's false, because even the uterus is contracting much, you can't push the baby out because it's the obstruction is somewhere. The obstruction is uh, behind the pubic symphysis. Hello, Shahan. How are you? Right? So, yes, Tushar. Yes, right. So, comments. Actually, what we are doing, we are stopping the syntocinon. You should not continue the syntocinon if you shoulder dystocia. That is false. Second, wide episiotomy. Right? Wide episiotomy is mandatory for release the impacted shoulder. Imelka, what do you think? Wide episiotomy?
False.
False. Yeah, because you are correct, Imelka. Because in in shoulder dystocia, the obstruction is behind the pubis, not in the perineum. So episiotomy will not help to deliver the baby. Yeah, that's false. Good. Macrobot position and suprapubic pressure will help to deliver more than 90% of shoulder dystocia. More than 90% of shoulder dystocia. Jasit, true or false? Macrobot position, suprapubic pressure will help to deliver more than 90% of shoulder dystocia. Yes, Jasit.
True.
Yeah, true. That's correct. So almost 90% of shoulder dystocia you can deliver with macrobot position and suprapubic pressure. So only 10% needed the additional maneuver, maybe internal maneuver or something, right? Okay, Riga, and fourth one, use of epidural analgesia is a risk factor for shoulder dystocia. What do you think about Nirosha? Nirosha, yeah, now put the short Niro. Yes? Use of epidural analgesia is a risk factor for shoulder dystocia. True or false?
False, I think so.
Okay, why you are thinking about false? Any explanation? Any idea? You are active student in my theory class, so then you might know. Yes. Why it's false? So in epidural analgesia, you might have a problem with straining, right? So patient might not push the baby out effectively. So that might need delay in delivery, not impact at behind pubis symphysis. So use of epidural analgesia is not a risk factor for shoulder dystocia. That is false. It can't be a risk factor for shoulder dystocia. So epidural analgesia is a risk factor for what? Epidural analgesia is risk factor for what? KW. Don't put the initial only. Then how can I call you? KW. So epidural analgesia is a risk factor for what? Huh? Yes, it's a risk factor for prolonged labor, which lead. If it is a prolonged labor, then what is the risk factor? Prolonged labor. Instrumental delivery. Yeah, instrumental delivery. Right. So if it is second stage prolonged labor, then you may have to put the instrument to deliver the baby. Okay. Right. Very good lesson. Right. So all four maneuver is suitable to deliver the shoulder dystocia in peripheral hospital. So if you are working in Mullaitivu like me, so if it is a shoulder dystocia, the all for maneuver, will it help? What do you think, Sachini Fernando? True or false? So I don't know. What is the reason? All the screen I could see most of them, almost 90% is girls. Why is that? Ashan, why is that? Boys are busy doing private practice.
Girls are smarter, I guess.
Oh, is it? Yes. So the Olfa Manoia is suitable to deliver the shoulder dystocia and peripheral hospital. Lasanda, good afternoon. What do you think? Alpha
Sure.
Manoia is true. Yes, true or false? Alpha Manoia is suitable for peripheral hospital. Yeah.
We can consider, right, sir? We can
No,
consider, right, sir?
no, it's not like that. The Alpha Manoia is suitable for the peripheral hospital. The reason is the Olfa Manoia, once you put the patient to other way around, to into Olfa position, then you are not supposed to do the internal maneuver. Even with the normal traction, baby will come out. So in peripheral hospital, sometimes you might not have the experienced personnel to deliver the baby, right? So for example, if it is a midwife-led hospital, some stations are delivering the baby with only might be a midwife. No doctors, no nursing officers, right? So there are so many places like that, right? So in that case, so they don't know how to do the internal maneuver. Sometimes they don't have much help to put the patient into uh, uh, s- macrobird position, suprapubic pressure, because we studied if you want to put macrobird position, you need two people to hold the leg. You need another person to give the suprapubic pressure. You need another person to give the traction. So altogether, minimum you need 3 people, 4 people. So some station in peripheral hospital, they are running with 1 or 2 midwives. So in that case, how can they put the macrobird position? How can they put the how can they give the suprapubic pressure? It's not possible, right? So because you people don't understand how the peripheral hospitals are running, how the peripheral people are suffering, right? So then if you now I'm thinking really we need to conduct the exam in peripheral hospital, then only you will get a lot of complicated cases. The patient will land to the hospital, hemoglobin 3, pregnant mother, massive antepartum hemorrhage, placenta previa. At 38 weeks only patient will land to the hospital. They never go to hospital, they never go to clinics, so no follow-up, right? So when we are, so I don't know why, so in Mullaitivu districts almost 40% of mothers are having diabetes, but they don't have facility to do the BSS. So what I thought is I plan to do, refer them to the base hospital to do the BSS, because for the BSS people are traveling for 40 kilometers. So they are having public bus, 2 bus per day. Morning 1 bus will come, evening it will go again. So just think how they are suffering. So then when I called to the base hospital, so can you do the BSS? Then only they said, even base hospital, only 2 midwives are there. No one is there. So how can you ask the midwife to do the blood sugar series? Right? So in that case, if you have less support, no people, no experienced person to manage the complications, so then easy way you can put the patient into all four position and pull the baby downwards direction, so then the shoulder will slip and come out, right? So the all four position is, you can consider in the tertiary hospital as well, but for the peripheral hospital, all four position is good. So that is true. So the answer is false, false, true, false, true. Okay. Question number 13 regarding RH isoimmunization. To occur, at least 5 milliliter of transfusion should be happening. True or false? Uvindu Bandar, what do you think? To occur, isoimmunization to occur, at least 5 milliliter transfusion should be happen. What do you
Yes, sir.
think?
Yes, sir.
Yes.
True.
So if it is less than 5 milliliter, then isoimmunization will not happen. Is that so?
It happens, but antibodies it is produced against that. It's not
Read
enough.
the question. Read the question carefully. Regarding the RH isoimmunization to occur, at least 5 milliliter transfusion should be happen. What is the meaning of that? If it is 5 only, there will be isoimmunization. If it is less than 5 ml,
Happen.
will it happen? If it is less than 5 ml, will it happen? Yes.
Yes.
Yeah. So then they mention to occur at least 5 milliliter of infusion should happen. So what do you think about this statement? It should be false. Even less than 5 milliliter can cause isoimmunization. According to this statement, they are telling. So these are the techniques I want to teach you, because you might know the stuff, but you don't know how to apply those things. But here, these are the careless mistakes, because you people know. So if it is less than 20 weeks, how much of Rogam we are giving? Nuan, Chandraratna. If it is less than 20 weeks, how much of Rogam we are giving? Yes, Nuan. How much we are giving? Any idea? Ubeksha?
250 international units.
Very good. It's 250 international unit. So 1 ml of fetal blood will be neutralized by?
125.
Very good. So 125. So if we are giving 250, means even 2 ml can sensitize. So if it is more than, less than 1 ml might not enough to sensitize, but if it is more than 1 ml, so it can stimulate the induce the isoimmunization, right? So to occur, at least 5 ml of transfusion should happen. False. Mother has to be Rh negative. What do you think, Sasna? Sasna, have you returned back to Sri Lanka or still there?
Return, sir.
Okay, good. So Rh isoimmunization, mother has to be Rh negative. What do you think? True or false?
True?
Yeah, of course. If mother is Rh negative, if baby is Rh positive, then only it will be it will be a sensitization. Otherwise, how? Yeah, it's true. Father need to be homozygous for the antigen. What do you think? What do you think? Father need to be homozygous for the antigen. Sanduni, what do you think? True or false? Father need to be homozygous for anti-D. Anyone? Hello,
False.
Shivaji. False. Why is that? Father need to be homozygous for anti-D. Shahil, what do you think? It's true or false?
I think it's false
Why?
because he can be a carrier and the mother is also a carrier, then the baby can be day negative.
So the RH antigen, is it a autosomal dominant or recessive? What do you think?
Recessive.
Yeah, it's a recessive. So if the father is uh, homozygous for anti-D, right? So small d, then 100% baby is going to be Rh negative. If it is a father is homozygous for capital D, then baby is going to be the capital D and small d, right? So if the father is heterozygous, then obviously baby might be so mixed one or disease one, Rh negative one. So you can't say father should be homozygous for capital D antigen. That is false. Bilirubin level in the amniotic fluid is increased. What do you think? Bilirubin level in the amniotic fluid is increased. True or false? Amanvi. True or false? True. Why? True. Why? In isoimmunization, bilirubin level in the amniotic fluid is increasing. Why? The reason is when the maternal antibody transfer to the fetal blood through the umbilicus, that antibody will hydrolyze the RBC, then there will be a RBC hydrolyzation, bilirubin level will goes up, and which lead bilirubin in the amniotic fluid. Why? What is amniotic fluid? How the amniotic fluid is formed? How the amniotic fluid is formed? Yes. How the amniotic fluid is formed? So
Urine
amniotic
output.
fluid is formed by the fetal urine. So if the fetal bilirubin level in the blood is increasing, what will happen? That will increase the amniotic fluid. Oh, that is your bilirubinuria. So if you have hemolytic anemia, what will happen to the bilirubin in your blood? Will go up, increase. So your amniotic fluid also will have bilirubin. Yeah, that's true. Chorionic villus sampling is a cause. RH isoimmunization, chorionic villus sampling. True. That's true. Right, that's true. So the answers are false, true, false, true, true. Right. Regarding preterm labor, pre-labor rupture of membrane, PLROM, which means regarding pre-labor rupture of membrane. So it means before she develop pain, before she goes to labor, her membrane got ruptured. So that is the question regarding pre-labor rupture of membrane. 90% will go to labor in 24 hours. What do you think? 90% will go to labor in 24 hours. Yeah, it's true. 80 to 90% will goes to labor within 24 hours. If not, then we may have induced with the prostaglandin. That is the normal progression of the labor in ruptured membrane. So please do question more and more, right? So take papers and do questions. If you have doubt, you can ask me, because practice make perfect. So you might think, so I did few papers, it's enough to your exam. It's not like that. Whenever you do more questions, you can easily pass. Whenever you do less questions, so then pass rate or passing the exam is difficult. Okay. Corticosteroid improve the neonatal outcome.
False.
We'll ask someone. Okay. Samira, what do you think? Corticosteroids improve the neonatal outcome. True or false?
False.
False. Pumila? corticosteroids improve the neonatal outcome. What do you think? True or false? So why I'm asking the question, why I am answering after that? Because if I answer the question immediately, you people will not think. So now, so if you are coming to the class at the beginning, of course, I need to teach you. Now you people studied already. Now you are waiting for the exam. So just imagine if you are an exam candidate, when you see this question in the exam, once you see, then you should know how I am thinking. Right? So it should be interactive manner. So you actively participate, please. So everybody, when you read the question, first you think your answer. Yes, this is true. So when today morning I send the paper, so then you do the paper. Keep the answer with you. If your answers are wrong, then you just think, why I thought like this? How the sir is thinking like this? Because this is something like concept based. You need to think the subject. Don't memorize the stuff. Okay, so most of the people answered the corticosteroid improve the neonatal outcome. Why? The corticosteroid will reduce the periventricular leukomalacia, it will reduce the necrotizing enterocolitis, it will reduce the respiratory distress, transient apneic. So there are so many advantages of um, dexamethasone. So in this question, corticosteroid improve the neonatal outcome. So if it is not improving the neonatal outcome, will you give corticosteroid to a patient, Damit? What do you think? Damit Dilsan, what do you think? So if the corticosteroid is not improving the neonatal outcome, then will you give corticosteroids? Yeah? Shahan, will you give? No. So then, so what about this statement? So regarding pre-labor rupture of membrane, corticosteroid improve the neonatal outcome. True or false?
So in this case, it's false, right, doctor? Because the patient is not a preterm patient, a preterm baby. So it's a post-term. So there's no reason for to give corticosteroids.
You can't say post-term, because the post-term, the word the post-term is beyond 42 weeks. Because the term is 37 to 42 weeks. So if it is less than 37 weeks, that is preterm. More than 42 weeks, that is post-term. So this is term, right? So pre-labor rupture of membrane. If it is a PPROM, preterm pre-labor rupture of membrane, then of course there are so many complications in the preterm. So the corticosteroids is beneficial for the preterm babies, not for the term babies. So you have to be very careful when you read the question. So everybody know, yeah, corticosteroid always we are giving. So you can't just tell corticosteroid, because it's not going to help for a term baby. Right? It's not going to help for the term baby. Right? So improve the neonatal outcome for term baby, not more than the term baby, the preterm baby, yes. So we take it as false. Risk of chorioamnitis increase 24 hours after PROA. What is it? Risk of chorioamnitis increase after 24 hours after PROM. True or false? That obvious, no? That's why what we do is we are waiting for 24 hours. 90% will deliver. If not, then we don't wait after that. We induce the labor and quickly deliver. Because waiting beyond 37 weeks will not have much benefit. At the same time, it has a lot of side effects. So risk of chorioamnitis increase after 24 hours. That is true. Ultrasound scan is used in diagnosis. Ultrasound scan is useful in diagnosis. Gayoshi, what do you think? Ultrasound scan is useful in diagnosis. Huh? I still not studied the lip language. You need to talk it. True. Okay. So, Shavin, what do you think? Ultrasound
Me?
scan?
I think it's false because the show of LICOA in the positive show diagnoses preterm rupture. I mean pre-labor.
What is show?
So it's the pooling of LICOA in the vagina.
No.
After.
Show is not pooling of lipo. What is show? Dilina, what is show? The show is blood stain discharge. Show is blood stain discharge. That is the feature of labor. Here actually the watery vaginal discharge, dripping. So you are correct. Pooling of lico into the POD is the diagnosis. Usually it's a clinical diagnosis. You can't diagnose with the ultrasound scan. Right? You can't diagnose with ultrasound scan. Because it's a clinical diagnosis, just history examination. So with the history and examination, you can simply diagnose whether it's uh, dribbling or not. Okay. So ultrasound scan is used in the diagnosis? No, ultrasound scan is not used. So the only thing sometimes we are doing with the ultrasound scan, you can assess the amniotic fluid index, whether it's markedly reducing or not, right? So whether it's compressing the baby, right? So if it is a artificial rupture of membrane, most of the water will leak. So then the less water around the baby will be less. So it's not help for the diagnosis. So ultrasound scan is used in the diagnosis, that is false. When diagnosis with group B streptococcus, prophylactic antibiotic B should be given before labor. M. Jayasinghe, what do you think? True or false?
True, sir.
Good. So good, because if the patient has group B streptococcus in the vagina, there is a high risk of ascending infection and causing endometritis as well as the fetal infection. So considering the complication, right? So what we do is we are giving the antibiotic one. Second, we may have to induce the labor immediately. We don't do the conservative management. Yeah, that's true. So when diagnosed with group B streptococcus, prophylactic antibiotic should be given before labor. That's true. So the answer for question number 14 is true, false, true, false, true. Okay, right. Question number 15. Causes for postmenopausal bleeding. Hypothyroidism. Chachini Vidanaji. Hypothyroidism. True or false? Yes?
False.
False. Yeah, that's true. Because the hypothyroidism can cause menstrual irregularity in a menstruating woman, not in the postmenopausal woman. Yeah, that's false. Endometrial polyp. Malshani, endometrial polyp. True or false? Probably next batch, next class, no one will come to the class. Oh, yes, true or false? Malshani disappeared now. Switch off the camera.
True.
Yeah, the endometrial polyp, yeah, it can cause postmenopausal bleeding. That's right. Endometrial hyperplasia,
True.
yeah, that's true. Endometrial hyperplasia can cause, no, because endometrial hyperplasia, endometrial malignancy can cause. Yeah, that's true. Atrophic endometritis. Atrophic endometritis, true or false? That is the commonest cause. Almost 60% of postmenopausal bleeding is due to atrophic endometritis. Yeah, that's true. Cervical malignancy. Cervical malignancy. Yeah, that's true. Cervical malignancy can cause. Yeah, that's true. So answer false, true, 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 true. Ectropion. Yeah, okay. Lasanda is asking. Cervical ectropion. Postmenopausal bleeding, cervical ectropion. True or false? Kamali, what do you think? Cervical ectropion? True or false? It's false, no? Because in postmenopausal ladies, the estrogen level will be less. So the ectropion risk is S. Okay, right. Question number 16. Which of the following predisposing factor to PPH? Caesarean section, Kavina Niroshan. What do you think? Caesarean section is a risk factor for postpartum hemorrhage.
True, sir.
Sure, yeah, of course. When compared to vaginal delivery, cesarean section is risk factor for the postpartum hemorrhage. That's true. So when you are doing the paper today, if you see somewhere, if you see whether the rat is went in or not, right? So if you are not concentrating the class, then I will ask question. Okay. So please concentrate. Otherwise, I ask a question. I am seeing the students. Definitely, I will ask. Yes, Janet. Yes. Right. So that doesn't mean if I'm asking some question that student is seeing somewhere, right? So I'm randomly asking, but if somebody sees somewhere, then definitely I'll ask. Okay, right. The breech presentation, predisposing factor for PPH, breech presentation. What do you think, Kaushalya? True or false? Kaushalya Ranasinghe. True or false? Breech presentation? Yeah, it's breech presentation actually false. Breech presentation is not a risk factor, but sometimes breech presentation might indirectly cause BPH because when we do the menovia, if it is a perineal tear, yes, there is a possibility, right?
Augmented labor is a risk factor for PPH, right, doctor?
Augmented labor, induction of labor is a risk factor, not the augmentation. Induction of labor is a risk factor for PPH, right? That is a common MCQ. You will get this statement, right? So augmentation of, not augmentation, induction of labor is a risk factor, right? So the breech presentation false, right? Oligohydramnios, what do you think? Oligohydramnios is a risk factor for. So how is my video? Is it lacking? Oh, it's normal, good.
Normal, doctor.
Right, thank you. So oligohydramnios, what do you think? Is a risk factor? True or false? Selani, what do you think? Oligohydramnios is a risk factor for PPH. True or false? Yeah, it's false. Because so over distension of the uterus might cause atony. But if it is oligohydramnios, uterus is smaller. Right? So it's not false. Retained placenta. Very good. Huh? You people are answering very well. So we can simply achieve 80%. Yes, Reshini. Retained placenta. True or false?
True.
Yeah, it's true. So because one of the tissue, there are 14 tone, tissue, thrombin, trauma. So the retained product can cause postpartum hemorrhage. That is true. So the answers are true, false, false, true, true. Okay, right. Question number 17. Regarding primary amenorrhea. Regarding primary amenorrhea. Androgen insensitivity syndrome characterized by XY. Okay. Yeah. Supun, androgen insensitivity syndrome characterized by XY. Yeah, that's true, no? Because they are basically male, but their androgen is not functioning. That's why they become as female. Right? So that's true, no? So if even though you are male, if you are not functioning like male, then you will be like a female. Am I right? Right? Okay, fine. So congenital adrenal hyperplasia has 21 alpha hydroxylase enzyme deficiency. Chintaka, what do you think? Chintaka Pidis. Yeah, it's true, no? The congenital adrenal hyperplasia. So we are having some problem in the cholesterol or steroid hormone synthesis, right? 17 alpha hydroxylase deficiency, 21 alpha hydroxylase deficiency, right? Okay. So PCOS is a common cause in developing countries. What do you think? PCOS is common cause in developing countries. True or false? Regarding primary amenorrhea, PCOS is common cause in developing countries. Ashan Senaratne, what do you think? True or false? It's obviously false, no, because PCOS is not the major cause for the primary amenorrhea. If it is a secondary amenorrhea, yes. If it is a secondary amenorrhea, yes. But if it is a first primary amenorrhea, that can't be. So most of the students say true, 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 because they are not reading the question properly. Jumping. So it's like that, no, when you see a statement, if you know something, then you are jumping without understanding. That is too dangerous. Whether you know or not, right? Carefully read and answer. So when I'm asking question, are you all suffering? No. So then somebody send text. So you ask, why are you so enjoying by making us suffer? Is that so? No. Okay. So answer. Right, fine. So the Turner syndrome has XX karyotype. What do you think? True or false? Turner syndrome is XX karyotype. Fantastic. It's false. It's X naught. Right? X naught. So that is false. Mullerian agenesis will have normal height. True or false? Mullerian agenesis will have normal height. Yeah?
True.
True. That's true. Mullerian agenesis, they don't have problem in their FSH-LH secretion, so their height is normal. Okay? So the answers are true, true, false, false, true.
Excuse me, sir.
Yes.
Regarding breech presentation in the previous question,
Right,
doesn't
yeah.
breech presentation cause prolonged labor and also high C-section risk?
So in breech presentation is a risk factor for prolonged labor. I agree. But the problem is in breech presentation, the prolonged labor is not much time, no, because we don't allow them for too much of prolongation, because even if it is deviate from the alert line, so then we are usually intervening, right? So that's why the breech presentation itself, it's not directly correlate with the PPH.
So, but the
So
intervention is also
if
C-section.
you say breech presentation might cause prolonged labor and PPH, then of course you have to tell another explanation. If it is a breech presentation or breech delivery, there might be a risk of perineal tear and PPH. which is a perennial tear which can cause PPH. Right? So like that it can correlate, because obstetrics, it's most of the time it's interconnected with the others. So the thing is, most of the answers are depend on the relative risk and the odds ratio, right? So those odds ratios. So when you see the books mention only the risk factor, means that is some kind of research odds ratio or relative risk. So you don't need to know those things, those words. But in breech presentation itself, so nowhere it's mentioned is a risk factor for the PPH, right? Okay. Okay, so it's another explanation. Breach itself, it's cause, but breach management can. Okay. Right. So the answer for that primary amenorrhea, true, true, false, false, true. Question number 7. Right. Question number 8. Evidence suggestive of malignancy in ovarian tumor during laparotomy. Evidence suggestive of malignancy in ovarian tumor during laparotomy. Blood stain, peritoneal fluid. Prahladan. True or false? Blood stain, peritoneal fluid. True or false? Prahladan. Huh? Unmute and answer.
False.
False. Sanjeevan, what do you think? So Sanjeevan, now it's ready for the exam. Haircut. So you short everything, right? You short your hair as well as your name. Earlier it was Sanjeevan, now it's Sanjeev.
It's true, sir. I didn't shorten my name somehow or other. It has got shortened. I think it's true, sir.
Yeah, it's true.
Yes.
Blood strain, ascitic fluid is a feature of malignancy, because the ascites may be due to several reasons, right? So if it is a liver failure, right? Several liver failure might lead to ascites, but if the ascites is due to malignancy, what will happen? Your peritoneum, it's highly vascularized, and while it is forming the ascitic fluid from the malignant surface, there might be bleeding which cause blood stain like so. I think I have taught this one. The features suggestive ultrasound, so exam history suggestive of malignancy, ovarian malignancy. Examination features suggestive of malignancy. Then the ultrasounds features suggestive of malignancy. Finally, laparoscopic features, laparotomy features suggestive of malignancy. Bilateral adhesions, right? Evidence of secondaries, blood stain, like there, blood stain, ascites, the eye features I told you. So this is how, right? So this is how the what we studied, it will be the exam, right? So blood stain, peritoneal, that's true.
Doctor, if it's blood stained, it's more likely to be metastasized. Like it's highly likely to be metastasized as well, right?
Yeah, but yeah, anyhow, it's if it is a benign, can you have the metastatic? No. So if it is a metastatic lesion, then what is it indicating? Obviously, malignancy. So okay, just tell me, can you have the ascites without metastasis? Why you are having ascites in ovarian CA? What is the reason for the ascites in ovarian CA? Rajit, what is the reason for the ascites in ovarian CA? Any idea?
Evolution, sir.
Infiltration of malignant cells into the peritoneal cavity is gonna cause ascites, angiogenesis, and neovascularization.
Who is in the bus? So I'm getting impressed. Even in the bus also students are studying. Ayyo, fantastic. Yeah,
Metastasis to the liver. Metastasis to the liver.
very good. There are two reasons. One, metastasis to the liver can cause ascites. One, but more than that, in ovarian CA, before the liver mets, they will have free fluid. The reason is the ovary will cover with by the peritoneum, not peritoneum, omentum, right? So the metastatic lesion can easily to the omentum as well as the peritoneal surface. Once the metastasis spread to the omentum, so then omentum and peritoneal surface start to secrete the exudate. And you might know what is exudate. What is exudate? Exudate, Anupama. What is exudate? What is exudate? Yeah. Fluid with high content of protein. Fluid content of protein is exudate. So in that case, what will happen? Ascites will have high protein and patient will be hypoproteinemia. Then again, it will increase the ascites. So yeah. So as you said, if it is an ascites, that is indicating metastatize. So if it is a malignancy only, it can metastatize. Then only you will have ascites. So ascites is a feature of malignancy. But especially in malignancy, ascites will be blood strain. Okay, that's true. Tumor size more than 20 weeks of period of gestation. Buddhika Bandhusena. What do you think? True or false? True or false? So these balcony people, why are they not all switch on the camera? Are they eating? Balcony.
Out of their beauty.
Yeah. So
Sir,
yes.
a quick question. So,
Yeah, sure.
what if it's something like endometrioma? Can you have blood-stained peritoneal fluid? Yes, right? And that's benign.
Right. Okay. What is endometrioma?
A collection of blood in the ovary.
Collection of blood in the ovary. So the explanation you have told. So if you have collection inside the ovary, how can you explain the blood outside the ovary? It's collected inside. If that blood want to come outside, then what has to be happen? The cyst wall has to be ruptured. If the cyst wall ruptured, how do you call that? That is called cyst rupture. So that is totally different. And other thing, endometrioma, is it a malignant one? Endometrioma, is it a malignant one? Yes or no? No, it's not malignant. So if it is not malignant, will you have metastasis? No. So in endometrioma, what do you think about your peritoneum? What do you think about the omentum? Will it be normal or will it have some abnormal cells? It's normal. If it is normal, just treat the exudate. No. So then how can you explain the ascites in endometrioma? Thank you for your question, right? So then a lot of people might have some clear idea. So in benign lesion, so you can't explain the ascites. Okay, right? And also you will not get any blood strain fluid in the endometrioma, right? So tumor size more than 20 weeks of period of castration is a malignant feature. What do you think, Senuri? Senuri Fernando, what do you think? True or false?
False, sir.
False. Why? Can you have a benign tumor more than 20 weeks? Yes, you can, right? So if it is a simple cyst can be 20 week size. The 20 week size is just up to the umbilicus. So you can have a large cyst. It might be a simple cyst. But if it is a multilocular cyst more than 10 centimeter, that is feature of malignancy. What is that rule? Aorta score. We studied those things, right? So those things, yeah, we'll revise tomorrow. So the aorta score, RMI score, we studied those things here. So in aorta score, the multilocular cyst is 1. So there are 5 things, no, in the aorta score. So one of the aorta score is multilocular cyst more than 10 centimeters suggestive malignancy. Here they didn't mention anything about the locular, or whether it's multilocular, whether it's unilocular. They didn't mention anything. Only they mentioned tumor size more than 20 weeks. Is it a malignant? No, it's not. You can't say it's malignant. If it is 20 weeks, it could be a normal cyst. Even I operate a cyst up to this sternum, benign one. Right? Simple cyst can go up to that level. It's a benign one, right? So that is false. Involvement of bilateral ovaries. What do you think? Involvement of Umadev and Tiripuran. Where are you? Involvement of bilateral ovaries. What do you think? True or false? So, you know, the Tiripuran is like, so when somebody propose, or maybe in the wedding day, the people are like feel shy to answer. Don't be like that. Answer the question whether it's correct or wrong. No worries.
It's true, sir. Bilateral.
Yeah, that's true. So that is one of the ultrasound feature. Bilateral tumor is one of the features. So in RMI score, one of the ultrasound feature is bilateral, right? So don't worry, we will revise, right? So it's in malignant tumor also can go up to more than 20 weeks. So can't we say false? Can we say false? Yes, because tumor size more than 20 weeks, if you say true, that is always it's like that. No, so you can't say true, no. If it is just because of more than 20 week size, you can't say this is malignancy, right? So that is false. So bilateral ovaries, then it's a feature of malignancy, right? That is a feature of malignancy. Presence of cystic and solidic area. Puviraj. Now I am going to ask the balcony people. Yes.
True, sir.
So presence of cystic and solid area. What do you think? True or false? Puviraj. Yeah.
True, sir.
True. Okay, very good. So presence of cystic and solid area. Yes, it's true because that is one of the ultrasonic features, solidic nature. Presence of smooth ovarian capsule. Actually, I love to see Puviraj's face, but unfortunately he feels shy and hide his face. So presence of smooth ovarian capsule. What do you think? True or false? Right? Presence of smooth ovarian capsule. True or false? Yes, true or false? Sanjay Disanayaka. True or false? It's false because the smooth surface, soft in consistency or firm in consistency, right? Regular border, those are benign feature. Those are benign feature, right? Irregular surface, right? Irregular border, hard inconsistency, those are malignant feature. When you come to the clinicals, right? So these are the features we are looking to find whether it's malignancy or not, right? These are the features we are looking to find. So when you examine the patient, you are looking these features. Okay, we are looking these features. So then when you present to the examiner, you have to tell those things. So there is a mass in the suprapubic region. It extends to right and left iliac fossa, also up to the umbilicus. It's roughly 20 week size of gravid uterus with regular border, smooth surface, firm in consistency, freely mobile longitudinally and vertically. I couldn't feel the lower border of the mass, right? So, and non-tender and normal in temperature. There were no ascites. There were no organomegaly, highly suggestive of simple ovarian cyst. This is how you need to present your history and tell your diagnosis, because smooth surface, regular border, freely mobile in longitudinal and vertical, so then it can't be a uterine mass, so it should be ovarian mass, and a smooth surface and regular border, so then it can't be a malignancy, so it should be a ovarian mass and benign ovarian mass. If it is irregular border, hard inconsistency, irregular surface, so then you can say it could be a malignant ovarian mass. You understand? When you come to the clinicals, this is how we will present. So these are the rehearsal. So how you are going to study in clinicals. When you come to the clinical, so then Lakshi has to present like this. Shahil has to present like this. Then I will correct it. No, this is not the way to present. You have to correct like this. You have to present like this. So then when you come to the exam, then it won't be a new thing for you. It's going to be a routine class. You just present to the examiner and come back. The first time you can't present very nicely in the exam. Don't think you can do that in the overnight. So you can't become Obama in overnight, isn't it? So you should be very careful. So you have to do more practice. Right. So the question. So the answer for question number 18 is true, false, true, true, false. Right. Question number 19. Regarding dysfunctional uterine bleeding, then do we say cystic component a feature suggestive of benign? Yeah, cystic mass is a feature of benign. Cystic with solid area, that is a feature of malignancy. Cystic mass is a feature of benign. Yeah, agree. So regarding dysfunctional uterine bleeding associated with anovulatory cycle, true or false? Dysfunctional uterine bleeding associated with anovulatory cycle. Shamira, what do you think? Dysfunctional uterine bleeding associated with anovulatory cycle. Yeah, when you have dysfunctional uterine bleedings, the extreme of age, reproductive age, most common in the perimenopausal age. Perimenopausal age, near to menopause. So near to menopause, when you get age, your organ function will affect. Agreeing? So your ovarian function will affect, endometrial function will affect, everything will affect. So when you are near to end of reproductive age, what will happen? Your endometrial function will affect. That's why you are having dysfunctional uterine bleeding. Same time, you might have association of this ovarian dysfunction as well, because ovary also got age. So if you have ovarian dysfunction, what will happen? Sometimes you might have ovulation, sometimes you might not have ovulation, like that. So it might associated with an ovulatory cycle. Yeah, that's true. It might associated with an ovulatory cycle. That's true. Dysfunctional uterine bleeding is a cause for enlarged uterus. What do you think? It's a cause for enlarged uterus. Pasindu? It's a cause for enlarged uterus. Dysfunctional uterine bleeding is a cause for enlarged uterus. Yes, Pasindu, what do you think?
It's false.
False. Anyone?
True, sir.
True. Okay. Shami, what do you think?
True.
True. Okay. So, what you understand by dysfunctional uterine bleeding? What is dysfunctional uterine bleeding?
Any amount of bleeding, not during, if it's between menses, it's not during, what do you call the intermenstrual period? If it's in that period, it's dysfunction.
That is intermenstrual bleeding. If you have bleeding in between the period, that is called intermenstrual bleeding. What do you think about what do you think about dysfunction? Something problem in the function, right? Dysfunction means something problem in the function. So where are you having the bleeding from? Bleeding from the endometrium. So endometrial dysfunction lead to bleeding. So how to diagnose it?
Ultrasound of the uterus.
Very good, Imelka. How to diagnose it? How to diagnose it? Yeah? How to diagnose it? Nirosha. How to diagnose the dysfunctional uterine bleeding? So actually, I think I have taught you this one. So dysfunction.
Doctor, so dysfunctional uterine bleeding and abnormal uterine bleeding is both the same, right? No?
I'm already under stress. If you make me more stressed, then definitely I will commit suicide. So what is this abnormal uterine bleeding? What is abnormal uterine bleeding? Normal uterine bleeding. So we discussed abnormal uterine bleeding is abnormality in your bleeding, right? It might be in the flow, might be in the regularity, might be in the duration. Yeah, that is your abnormal uterine bleeding. So your dysfunctional uterine bleeding is one of the abnormal uterine bleeding, one of the cause for the abnormal uterine bleeding. So we discuss a lot, palm, coin, blah, blah things. Now everything we forgot, right? So in coin, the functional dysfunction, that is an endometrial dysfunction. But we don't have any measures to identify the endometrial dysfunction. That's why the dysfunctional uterine bleeding is a exclusion of the other cause, diagnostic exclusion. So it means your history suggestive of bleeding, but your examination is normal, investigations are normal, ultrasound scan normal, endometrium, the histology is normal, but still she's having bleeding. So it could be due to dysfunction, because we don't have measures to assess the endometrial function. So the dysfunctional uterine bleeding is a diagnostic exclusion. It means your uterus and the investigations, everything looks normal. So can you have enlarged uterus in dysfunctional uterine bleeding? If the uterus is enlarged, what is the meaning of that? Something problem in the uterus. That is the reason for the uterine bleeding. For example, is adenomyosis. So then how can you say it's dysfunctional uterine bleeding? So it can is a cause for the enlarged uterus? No, that is false. That is false. Diagnosed by MRI. Dysfunctional uterine bleeding diagnosed by MRI. It's false. No, now only we discuss. There is no measures we are having to assess the endometrial function. It's false. So improve by dilatation of the cervix and curettage. Dysfunctional uterine bleeding improve by dilatation of the cervix and the curettage. Yes, VMW. Why can't you change to BMW rather than putting VMW? Then it will be cost, no? Yes, VMW. What do you think? It's improved by dilatation of cervix and curettage. True or false?
False.
Your answer should be very, very, very expensive. Huh? Yes.
False.
Yeah, it's false because the dilatation and curettage is a, what is that? KW? What do you think? Dilatation and curettage. What do you think about KW? It's a diagnostic modality. It's not a treatment modality. Right? So the DNC is the way to take the biopsy. There is not a treatment. So by diagnosis, can you have a improvement? What do you think? No. So it's obviously false. So how simple this option gynae, if you understand. If not, it's difficult. No, that's why I'm always telling. So when you see, when you feel, when you see the subject, it's looks simple, but when you do, it's difficult. But if you understand, it's easy. Same as female, right? So think that, isn't it, Chan? Okay. So treat with the progestin containing IUCD. Dysfunctional uterine bleeding is treated with progestin containing IUCD. Yes? What do you think? True or false? Yeah, that's obviously true, because where is the problem? The problem is in the endometrium. So if you want to stabilize the endometrium, so then it will be, the bleeding will be settled down. So how can you stabilize with the progestin? So the first line treatment is that. So the answer for question number 9 is true, false, false, true. True, false, 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 true. Right. Question number 10. Polycystic ovarian syndrome. Oligomenorrhea is a feature. Tilina, what do you think? Oligomenorrhea is a feature. Yes, Tilina. True or false? So this is also a problem in the online class, because you people are keeping the camera somewhere. When I'm asking, when you see, so I feel some kind, so you are answering to somewhere, but I am looking at you. So if it is a live class, it won't happen, no? So I'm like to start a live class zone, right? Fine. So oligomenorrhea is a feature. So we know the in Rotterdam criteria, oligomenorrhea is one of the clinical feature. So what do you think? Can you have a normal vaginal bleeding in PCOS? Yes. Yeah. Around 20 to 25% of girls will have normal vaginal bleeding. So then you can't say, as I'm having regular bleeding, I don't have PCOS. Still, you can be a PCOS girl. You understand? So the normal vaginal bleeding can be there for a PCOS also. Yes, signal is okay, but then and there the power cut will occur. That's why we got stuck. Okay, fine. So polycystic ovarian syndrome, oligomenorrhea is a feature too. Clomiphene citrate can be used as treatment in subfertility. Clomiphene citrate can be used as treatment in subfertility. True or false? Aisha, what do you think? True or false? Yes. True or false? So clomiphene citrate, of course, you can use, but we don't use the clomiphene citrate as a first-line treatment. The letrozole is the first-line treatment because risk of multiple follicular development and ovarian hyperstimulation syndrome. That's why we don't use as clomiphene citrate as a first-line treatment. But clomiphene citrate can be used as a treatment in subfertility. Yeah, that's true. That's true. We can't say false. Yeah, fine. Hirsutism is a feature. Hirsutism is a feature. Yeah, that's a feature, no? Because hyperandrogenism is a feature of hyperandrogenic feature or evidence, biochemical evidence of hyperandrogenism is a feature of PCOS. Yeah, that's true. Predisposed to cervical carcinoma. cervical CA predisposed to PCOS predisposed to cervical CA. True or false? Netmini, what do you think? Netmini, true or false? So it's false. So the cervical CA, it's not a risk factor for this PCOS, but endometrial CA is a risk factor for the PCOS because unopposed estrogen therapy for a long time, which can cause endometrial CA. Yeah, that can be a cause for endometrial. Endometrial CA is a feature of PCOS. Yeah, that's true. FSH level higher than the LH level. FSH level is higher than the LH level. What do you think? So other way around, no? LH level higher than the FSH level. That is the PCOS feature, right? Because multiple follicular development got arrested in halfway, so the estrogen will inhibit the FSH secretion, so which lead to reduction in FSH concentration. But FSH and LH will be in the normal range, but the LH is higher than the FSH. That's the answer. You know, when the time is passing 2 o'clock, most of the cameras are now focused to the ceiling. You know why people started to eat? It's unfair. When I am teaching you without eating, if you focus the camera and eating, it's not good. No, you will develop peptic ulcer disease, definitely. Right? Okay, fine. So the answers are true, 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 false, false. Okay, fine. So we finished the paper 1. So the students who came to the paper revision, so I have complete the paper revision question 6 complete question. So we will do few SBA questions from paper 2, and rest of the paper actually I will be in Colombo next Friday. So then the Friday I will do this one. One repeat, that session 1 repeat session. So the topics wise revision, so every other week you will have 2 class, and every other week you will have 1 class. The purpose I put the class 1 class per week because this is a revision. So when you are coming, so I will teach you something, then you have time to revise what we study, because I'm not going to tell everything. So I'll quickly tell the summary and new things, something like some minor topics. Then you need to read those topics, and you need time. So that's why I didn't put back-to-back class. So if I put back-to-back class, I can just finish the syllabus within 2 weeks, then you will be in trouble. So that is not good. So what can I do is I can just do something and give you some time, then you can go and read. You have time. Then next week I can do rest of the topics, right? So next Thursday and Saturday we have a topic wise revision. So Friday we'll do some other things, so that paper class morning time we can do this paper revisions, right? So the free paper revisions. So I will do one paper revision next week as well. So maybe next week, and after that next week also I can do something. So yeah, okay. We will do paper 2, right? Paper 2, SBA. All right, paper 2, SBA. The first question. Is it okay? Shall I do the paper 2 SBA? Right, fine. A 26-year-old multipara is admitted to hospital at 36 weeks of gestation following an episode of antepartum hemorrhage of approximately 300 cc. The bleeding has ceased on admission. On examination, she's not pale, blood pressure 120/80, and pulse rate is 76. The abdomen is soft and non-tender. The fetus is in breech presentation. There are no palpable uterine contraction. The fetal heart rate is 140 beats per minute. What is the most appropriate next step in management? What is the most appropriate next step in management?
Examine the cervix using Casco's bivalve speculum.
B. Indunil, what do you think? What is the answer? Pasindu want to mark as E. Right. So what could be the probable diagnosis here?
Vaginal trauma.
Vaginal trauma. Why you are thinking about vaginal trauma? Anyone? Any idea? What could be the probable diagnosis here?
Placenta previa.
It's a placenta previa. Yeah, very good. So because the most of the features, always when you read the question, right, you should be very careful when you read the question. You need to understand properly, right? So what are the important things? 26-year-old multipara, 36-week following episode of antepartum hemorrhage, 300 cc. So multipara, right, got admitted with APH. So in that case, you need to think what could be the reason for the APH. Whether could be a placental cause or non-placental cause. So the placental causes are placenta previa, placental abruption. Or maybe vasa previa. You have 300 cc of bleeding in vasa previa. What do you think, Shahil?
No, sir.
No, obviously no, because the fetal blood volume is 150, 160 ml. So 300 means it can't be a vasa previa. So it could be a placenta previa or placental abruption. That is placental cause. Or maybe a non-placental cause, like as you said, trauma. So if it is a cervical infection also, it's unlikely to cause 300 ml of APH. So the cervical trauma is the third cause for this antepartum hemorrhage. So here they have further mentioned the bleeding has ceased on admission. So the bleeding stopped spontaneously. Examination, she's not pale, right? Her blood pressure is normal. Pulse rate is normal. She's not pale. Blood pressure is normal. Pulse rate is normal. So in that case, patient is stable. She doesn't have much bleeding, right? And bleeding spontaneously stopped. Only she has 300 ml of APH. On examination, abdomen is non-tender and soft. So what you can understand from this word?
It's not placental abruption.
Yeah, it can be. It's less likely to be a placental abruption, because if it is a placental abruption, then uterus will be tender and the woody heart. So it's less likely to be a placental abruption, right? So it could be a placenta previa or could be a trauma still, right? And further they mention the fetus is in breech presentation. So at 36 weeks, if the baby is breech presentation, if she has any of the risk factors for the breech presentation. So the placenta
previa.
Yeah, placenta previa is a risk factor for breech presentation. So that is the information you need to gather here, right? So it's high likely to be a placenta previa, right? So the fetal heart rate is 140. What is the most appropriate next step of management? What is the most appropriate next step of management? Yes. What is your answer? Puragaladhan is still adamant. No. Whatever you say, it's B. What is the answer? B. Oh, obviously now we know. So our differential diagnoses are maybe a trauma or maybe a placenta previa. So for that, as Shahil told, we need to do the Casco-speculum examination to exclude the local cause. And we have to do the ultrasound scan to exclude the placenta previa. These are the two answers. among these two, which one is best? The other answers we can exclude, because administered dexamethasone, of course, we have to do, but not now, or maybe after this find out the cause. So, and examination, so the pelvic examination and anesthesia, it's not doing, right? And performing CTG, of course, we have to do the CTG. So first we diagnose the patient, assess the baby, mother, then then we are going to assess the baby. So what is the next step? CTG or cusco-speculum examination or uterus? I can make different questions from this scenario. Don't worry. I will tell you some different questions from the same scenario. Yeah, in this scenario, what is the next step? So always, so you have to assess in case of APH, you need to assess whether the first thing we are assessing whether mother is stable. Second, we are assessing whether baby is stable. Agree? Here, mother also stable, baby also stable because the heart rate is normal. So then what you can do, you can diagnose the patient and you do the management. Agree? Right, okay, fine. So here, mother, baby stable. What is the next step? So always you have to keep in your mind history, examination, and investigation. So you have taken the history, you have done the examination, abdominal examination. Then before you go for an investigation, what is your next step?
Anal examination.
Cusco-speculum examination. That's why the next step is going to be the cusco-speculum examination. Then once you exclude the other cause, then we'll go for the ultrasound scan. Okay. So then when you do the ultrasound scan, then next you have to do the CTG. Say for example, now the same scenario, heart rate is 110. What is the next step? Mother is stable. Mother is stable. Abdomen soft, non-tender. Heart rate is 110. What is the next step? Here they have mentioned heart rate is 140. Here they mentioned heart rate is 110. What is the next step?
Cardiotomogram.
Then CTG. You can't say, no, I will do the ultrasound scan, I will do the speculum examination, then only I will put the CTG. Because here heart rate is abnormal, then you need to give the priority to the baby. You are breaking the rules, put the CTG and assess how the baby. Right? So then you can do the rest of the things. If the baby has kind of bradycardia or deceleration, then you can do cesarean section. Expedite the delivery. You understand how to approach the question, right? So this is how I am telling. So in theory class, tomorrow revision class, what we are going to do, we are going to study the theory. So especially in theory, what we study the background knowledge. But in revision or maybe the paper class, only we are applying the background knowledge on the question. Right? So that we are applying those things on the questions, how to apply your knowledge. So in obstetrics, there is no fixed rules. So always you have to read the question, identify the problem. So rational thinking with the background knowledge we are applying. You understand? So you can't say this is the order I will do. So we can break the rules sometimes. Okay. Okay, if they ask what is the best step or best step in her management, they're not asking about this patient. What is the best step in her management?
To observe and
among these answers, they're asking what is the best step in her management.
ultrasound examination of the uterus.
Ultrasound scan, because here we know it's mostly high likely to be a placenta previa. So what you want to do first, what is the best thing you need to do? First, you have to confirm your diagnosis. That is the best thing. As they ask the next step, you mentioned that. But if they ask what is the best step, then it's going to be the ultrasound scan. Do you understand? So if you have that background knowledge, only you can rationally think. So please don't go with the confined things. It should be a kind of rational thinking. Okay, right, fine. So the answer is pelvic examination. Examination of the cervix using the Kaskos bivalve speculum. That is the next step. But the best step is going to be ultrasound scan. So the order of examination, so order of management to this patient, you just do the speculum examination, do the ultrasound scan, put CTG. If everything is fine, as Shahil told, we can continue the conservative management. You don't need to be hurried to do cesarean section because bleeding has been settled, patient is stable, baby is stable. Still you want to cut the mother. What do you think, BMW? Still you want to cut the mother? No. You don't need. So you can do the conservative management. Okay, right, fine. Question number 2. A 16-year-old girl presented with primary amenorrhea. Her height is 5 feet. She has no secondary sexual characteristic. Examination revealed the presence of uterus and the vagina. She has high FSH and LH level with low estrogen level. Karyotype is XY. What is the most appropriate diagnosis? Absence of Mullerian inhibition, gonadal agenesis, hypogonadotrophic hypogonadism, testicular feminization, Turner syndrome. Sivadevan is firing. Kitimini, you are very careful. Huh? He is firing more. Yes, Sivadevan, you are correct. So what is the answer? Testicular feminization syndrome. So do you believe this testicular feminization syndrome? So the people who are selecting testicular feminization syndrome, you should be very careful. So the testicular feminization syndrome people are very beautiful girls. Isn't it? That's why that day when Pragaladan talked to me, he told he never marry a beautiful girl because until he know the karyotyping, he will not marry a beautiful girl. Isn't it? So because they are having high level of estrogen, but they are having good secondary sexual characteristic, but they don't have uterus. But here they mention examination revealed presence of uterus and vagina. They are having uterus, they are having vagina, but they don't have a secondary sexual characteristic. They don't have secondary sexual characteristic. No secondary sexual characteristic. No uterus, but they have uterus, they have vagina. Primary amenorrhea at 16 years. What could be the reason?
Absence of inhibition of Mullerian.
Absence of inhibition of Mullerian duct. So if Mullerian duct is inhibited, karyotyping is XY, Mullerian duct is Mullerian duct not inhibited, then what will happen? They will have uterus, they will have tubes, same time they will have male internal organ, right? So male internal organ like vas deferens, seminal vesicle, right? Everything, testes. So actually they are having both male as well as female. When I'm teaching this one in a live class, one student asked me, so in that case, can that person produce her own baby? Because that person has testes, that person has uterus. So can they produce their own baby? What do you think? They're having both. What do you think? Shamika, what do you think? Can they produce their own baby? No, the thing is, as they are XY, they are having only testes. There is no ovary, there is no egg. But they are having female internal organ. Female internal organ is there, male internal organ is there. Gonad is actually male. So they can't produce the baby, their own baby. Now here, the Mullerian inhibition is not the answer. So what could be the answer is the gonadal agenesis. Why the gonadal agenesis? So basically, maybe chromosomal arrangement is XY. It means genotypically that person is male, but due to some reason, the gonadal ridge not develop. So if the gonadal ridge not develop, what will happen? There is no gonads, no testis or no ovary. So in the absence of testis, if the testis is absent, no testosterone, no MIS. So without testosterone, the male organ will not develop. Without MIS, the female organ will develop. That's it. So they are genotypically male, but phenotypically female, but there is no ovary. So then no more secondary sexual characteristic development. So the answer is gonadal agenesis. Question number 3. A patient who has undergone an uncomplicated abdominal hysterectomy start to leak urine while the catheter in situ. Which one of the following injury could most likely to have during the operation? Cutting the ureter while removing the cervix, injuring the bladder while dissecting the uterovesical peritoneum, actually it's a peritoneum. So ligation of the ureter at the infundibulopelvic ligament, ligation of the ureter at cardinal ligament, ligation of the ureter while suturing the vaginal vault. That is the answer. What is the answer? It is kind of bit difficult question. Yeah? Anyone? What is the answer? So here, what is the diagnosis? Madhu, what is the diagnosis? What's the diagnosis? Damage to ureter, vesicovaginal fistula. Anyone? You understand how you are getting the question? It's what is the diagnosis? Shahil, what's the diagnosis?
Oh, sir. It could be anything. It could be injury to the bladder, ureter, like surgery. So
You can diagnose. It's simple. So if you understand the basic, you can simply diagnose. Here, read the question carefully. The patient who has undergone uncomplicated abdominal hysterectomy start to leak urine while the catheter in situ. So it's meaning while the patient on catheter, she is leaking. So if somebody has catheter, what will happen? Once the urine comes to bladder, that will drain through the catheter. So the catheter will be empty, bladder will be empty while patient on catheter. Agree? Yes. So while the bladder is empty, still the urine is leaking to the vagina. So then where could be the lesion?
Ureter, right?
Yeah, it should be higher up.
Ureter.
It should be higher up because kidney, ureter, bladder, urethra. So your bladder is empty but still leaking means the urine is leaking from higher up. So should be from the ureter. So the diagnosis should be ureterovaginal fistula. The fistula, connection between ureter and the vagina. So the diagnosis is ureterovaginal fistula. Ureterovaginal fistula. It can't be a vesicovaginal fistula. If it could be a vesicovaginal fistula, but if it is a vesicovaginal fistula, once you put the catheter, there won't be leakage because nothing inside the bladder. So it should be a vesicovaginal, so ureterovaginal fistula. So what are the areas you can tie, or you can tie the ureter and the vagina? So what is the commonest area we can damage the ureter? So what are the areas you can damage the ureter? One, you can damage in the infundibulopelvic ligament, or you can damage during the cardinal ligament, or you can damage while you are tying the ureter with the vault. Those are the common area you can damage it. Got it? You can damage it. So here what we do is, right, so the question is vesicovaginal fistula, right? So sorry, ureterovaginal fistula. Give me 1 minute. What is the question? So the following injury most likely have happened during the operation. So the commonest area you can have the ligation or damage might be in the infundibulum, so your cardinal ligament at the level of cervix. So you might tie while you are tying the cardinal ligament, right? Even after tying the cardinal ligament, it won't directly cause to connection to the vagina. But if you tie the ureter with the vaginal vault, what will happen? Ureter and vagina, it's tied together. Once you tie together, what will happen? There will be abnormal connection and you will start to leak. So what could be the answer then?
B, right?
B, where you are tying the vagina and the ureter. Ligation of the ureter at the cardinal ligament, that is D. Ligation of the ureter while suturing the vault. What is vault? Okay, I think you people forgot the anatomy. Don't worry. This is your tube. This is your ovary. Ovary is attached to the lateral pelvic wall with the infundibulopelvic ligament. Right? This is your vagina. Your ureter is coming in the lateral pelvic wall and come across through the vagina and enter into the bladder. This is how, right? So when you tie the infundibulopelvic ligament here to remove the ovary, you might damage the ureter. That is one area. Second, this is your cardinal ligament. When you tie the cardinal ligament, you might damage the ureter. That is second area. Third one, after removing the uterus, when you are tying the vaginal wall like this, you might damage the ureter. These are the three commonest area you can damage the ureter. Here, what has happened, your ureter has connection between the vagina. That's why the urine is leaking through the vagina. So, if you damage the ureter at infundibulopelvic ligament, can you have connection between ureter and the vagina? What do you think? The ureter is somewhere, vagina is here. If you damage here, can you have the abnormal connection? What do you think? No. So, ureterovaginal fistula risk is less if you damage at the infundibulopelvic ligament. So, if you damage the ureter with the cardinal ligament, you are near to vagina. So, then there will be a chance of fistula. Agree. There will be a chance of fistula. That is also agreed. So, if you damage the ureter while you are suturing the while you are suturing the vault, if you damage the ureter while you are suturing the vault, what will happen? The ureter and the vagina will tie together. So then what will happen? There will be a leakage. So if you damage while you are suturing the vault, the risk of ureterovaginal fistula is high. So what is the answer then? What is the answer then?
E, right?
E. Yeah, it's a bit difficult question. No problem if you don't know, right? Somebody might understand, somebody might not understand. So some juniors are there, so it's okay, no problem, right? So if you don't understand, no problem, but at least you should have some idea, right? Question number 4. Patient who had undergone abdominal hysterectomy 5 days ago complained of watery blood discharge from the abdominal wound. When the dressing was opened, the wound was found to have given away completely. What is the most appropriate treatment? Admit to ICU, apply through and through suture after giving IV antibiotic, suture after the infection subside completely, suture each layer separately immediately under GA. Yes. So the previous question somebody asked, can't be A, cutting the ureter while removing the cervix. If you cut, if you are not tying, then the fistula risk is less. If you tie only, the risk is high. What is the answer for question number 4? Patient undergo abdominal hysterectomy 5 days ago, complain of watery blood stain discharge. So completely given away, completely. So it's a the vagina, it's separated. So what is the most appropriate treatment? D, suture after infection subside completely. So what is this? It's actually the wound adhesion secondary to infection, right? So wound adhesion secondary to infection. So obviously what you have to do is here for the wound adhesion, you don't need to keep the patient in ICU until the patient has features of sepsis. If the patient has features of sepsis, obviously you have to admit the patient into the ICU and monitor for the features of end organ damage or multi-organ failure, and you need to give antibiotic. So here, if the patient doesn't have features of sepsis, you can treat even after as outpatient or maybe your inpatient with the IV antibiotic. So what we do is we give IV antibiotic and daily dressing. So because with the infection, with the organism, you can't put stitch. If you put stitch, again the infection will get worse and patient will have again wound adhesion. So until the wound infection completely resolved and until the granulation cells form. So the thing is, once you cut the mother, right? So during surgery, once you cut the mother, these edges are very clean and very healthy. they have enough vascular supply, healthy tissue. So if you put the stitch, those healthy tissue will join together. The healing will be high. Right? Give me 1 minute. Right. So, so if it is a clean cut injury immediately after the surgery, even if you put the stitch, immediately it will heal because it's highly vascularized and normal tissues. Right? But if it is an infected wound, the cut edges are not healthy. The vascularity is not good. So you need to leave some time until the granulation cells form. What is granulation cells? That is the highly proliferative, highly vascular cells which can heal easily. So once the granulation cells form, then only you can put the stitch. How do you call that stitch? That is called secondary suturing. That is called secondary suturing. So we are putting the secondary suturing once the healing complete. Sorry, once the granulosa cells formed well. So until the granulosa cells form, then you need to wait with the antibiotic and dressing. Then once the granulosa cells form, then we put the stitch, secondary suturing, and it will heal. So here they have mentioned, so what is the most appropriate treatment? ICU, no need. Apply through and through suture immediately, no, we don't. Suture after giving IV antibiotic for 48 hours, we'll see. Suture after the infection subside completely, that is the answer. Suture is each layer separately immediately. So we are not suturing immediately, we are just waiting until the granulation cell forms, then only we put the stitch. Okay, so the answer is C. Right. Question number 5. 35-year-old multiparous woman who has an IUCD complaint of offensive fishing.
Excuse me, sir.
Yes.
So is it number 4? Is it answer C or D, sir?
Sorry, D. Complete subs, right? Then we have to put
complete.
the
Yeah.
because in 48 hours we can't we don't know whether it's completely subside or not. So once the granulation cells form, then only you can put it. Right? Yes, good. Okay, fine.
Thank you.
So question number 5, 32-year-old multiparous woman who has an IUCD complaint of offensive fishy smelling jelloish discharge without pruritus. Her first pregnancy has ended up in preterm labor. Vaginal pH more than 4.5 grams straining, Vaginal smear shows reduced number of lactobacillus, large number of gram-positive and gram-negative cocci. What is the best treatment option for this patient? Yes, Madhu, what is the answer? Yes, what is the answer? What is the diagnosis, Chamantika? What is the diagnosis, this one?
Bacterial vaginosis.
Yeah, it's a bacterial vaginosis, very good, because offensive fissure vaginal discharge, that is one feature suggestive of bacterial vaginosis, right? And second thing, the first pregnancy ended up in preterm delivery. Again, the bacterial vaginosis is a risk factor for the preterm delivery. That is second feature. Third one, the vaginal pH is more than 4.5. So that is the most likely cause. Yeah, bacterial vaginosis. Again, so the gram strain, so the reduced number of lactobacillus, yes, that is another feature of bacterial vaginosis. Then large number of gram positive and gram negative cocci, so it's bacterial vaginosis. But for the confirmation, what we are doing, what is the investigation now? What is the criteria we are using to confirm the bacterial vaginosis? Is Amsel criteria, no? Amsel criteria. That is the criteria we are using to diagnose the bacterial vaginosis, and treatment for the bacterial vaginosis is simple. It's metronidazole. Metronidazole is the treatment for the bacterial vaginosis. So the answer is E. We'll do question number 6. A 35-year-old multiparous teacher with diabetes mellitus complains of severe genuine stress incontinence. She has second-degree uterovaginal prolapse. What is the next step of management? A 35-year-old multiparous teacher with diabetes mellitus complains of severe stress urinary incontinence. She has second-degree uterovaginal prolapse. What is the best management option? Vaginal hysterectomy and insertion of tension-free vaginal tape, Birch-Kolper suspension, pelvic floor exercise. What is the next step of management option? Pelvic floor exercise, vaginal hysterectomy, Helix repair, insertion of vaginal pessary. Yes.
Insertion of pessary.
Why? She's 35, man. She might be sexually, not might be, she is sexually active. So insertion of pessary might affect her sexual life. So you can't just arbitrarily tell, I will insert the pessary. Isn't it? So read the question carefully and answer. What are the problem you identify? What they're expecting from you? Then only you can tell your answer. "35 years. Is it significant? Yes. She's quite young. Right? Multiparous. So the multiparous, it's not saying she complete the family. Right? So even after 10 baby, mother might think, no, I need to deliver one more. That's her rights. Can you limit her family, Piragaladan? No. You don't have rights to limit someone's family. Isn't it? So that is her rights, whether I want to limit the family or not. So diabetes mellitus, she's diabetes, right? So that is, the diabetes is not a contraindication for any surgeries. So you can go for the surgery. Severe genuine stress incontinence. She's having stress incontinence. Okay. And second-degree uterovaginal prolapse. So obviously, as she has second-degree uterovaginal prolapse and the stress urinary incontinence, you need to do some surgical intervention. There is no question on that. So the question what they're asking is, what is the next step of management option? She's having stress urinary incontinence. she's having second degree UA prolapse. She's 35 years. What is your next management? Ragalajan, what is your next management? What you will do next? Will you cut the mother immediately, or before that will you do something to her? Yeah? We have to offer the conservative part. That is the first one. Before you do the surgical management, first step, you need to do the conservative part. Then only the next step is surgery. What is the conservative part? Immediately you have to offer to her the pelvic floor muscle exercise. If you offer the pelvic floor muscle exercise, she will get some symptom relief. Along with that, only you have to give the surgical management. So the question is, what is the next step of management? So this is how you people get wrong answers. You are thinking about the definitive one. The definitive one, of course, might be Birch-Colpo suspension, or maybe, as you said, if the patient said, no, I don't want uterus, you can take my uterus out, then of course you can think about the hysterectomy and the tape procedure. That is the definitive one. But the question is, what is the next step of management? That is pelvic floor muscle exercise. Okay, so the answer is C. Okay, right. So I need to go at 3 o'clock. So we'll finish this one today. So we will have the balance on Thursday morning, 6:30, right? As we planned. Because coming tomorrow, 7 o'clock, we are having system-based revision. So then again, Thursday evening we are having, and Saturday again we are having, and Friday we are having the revision session. We can use that 4 hours part for that one. So the Tuesday morning we'll do some revision part. We'll see. Okay, I'll update you regarding that restreaming part, and of course the system-based revision will start tomorrow. So the schedule, what are the topics we are going to discuss, I have mentioned in that that post. You can go through it. Okay, so study well. If you have any doubt, you can ask me.
Excuse me, sir, can I ask you a question quickly?
Yes, Sanjeev. Yes.
You said the commonest cause of postmenopausal bleeding is atrophic vaginitis. So we had a question in one of those previous questions. So you said atrophic endometritis is the commonest cause, or 60% or something like that. So the mechanism of atrophic endometritis is the same as atrophic vaginitis because of lack of estrogen, is it right?
Same. Because your vascular integrity will lose and vascular rupture can lead bleeding. Because absence of estrogen will cause the reduction in collagen synthesis. So the integrity of the vessels will lose. So the fragile vessel can easily rupture and bleed.
Okay. Thank you. Thank you.
Okay. So in first question, even though the history suggests you a placenta previa, so before you do the scan, right? So for example, if sometime ultrasound scan might be a transvaginal scan. So before you offer the transvaginal scan, always if the patient is stable, first you have to do the examination. That is the next step. Then only you have to go for investigation. That's the reason. Okay, so then we'll meet on tomorrow. Bye. PV bleeding, always next step will be the speculum. That's why I told you, that's depend on the clinical scenario. So if the fetal heartbeat is abnormal, then we have the CTG will be the next step. So don't memorize the stuff like that. What is the next step? Don't memorize it. Read the question, depend on the scenario, you have to answer. Okay? Can PCOS cause ectropion? Any condition which lead estrogen excess which can cause ectropion. So PCOS directly, they are not mentioning the PCOS is a risk factor for the ectropion, but in PCOS, ectropion can occur because continuous estrogen exposure can lead to ectropion. With UV prolapse, can we do pelvic floor exercise? Of course, Lasanda. What's the problem? You can. So shouldn't we exclude the placenta previa first, then we are not going to do the vaginal examination, we are doing the speculum examination. You should not do vaginal examination without ultrasound scan. This is speculum examination. Okay, right. Yeah, we can do iPhone, yes. Tushan, in 10 minutes. Okay, so then we'll meet tomorrow. Bye.